of the session. Well, welcome to week 6. Those of you in Professor Morris's class will be getting this recording. Also, you all don't know, or maybe you do, I do have a YouTube channel. So it's Professor Bogart's Pediatric Nursing, and it's on YouTube. So all my recordings, dosage calc review is in there, and all my Kahoots. So you do have access to all of that also. So the way I run my class is initially, I ask if anybody has any issues, problems, concerns. Let's get them out of the way in the first. So does anybody have anything they need to discuss, or you all are okay with what's going on in the class right now? Okay. So this week, we're week 6. We are halfway through now. It's quite amazing how quickly it does go. It does get a little bit crazy for y'all, especially if you're in the 3 classes, because you do have community, just had an exam or going to have an exam this week. And next week, we're having the exam for pediatrics. Now, we've sent out the review schedule. I do the first review on Thursday evening at 5:30. Professor Okorafor does Friday at 6 o'clock, and Professor Morris has at 6 o'clock on Saturday. Now, if you look at your calendars, all of you should have them in the calendars with the Zoom link. So it's very easy. You don't have to look at announcements, just go to your calendar. And I was able to put that in all of the Canvas shells. So that is there for you. Your exams will be given during class time as normal, so just come a little bit earlier next week so that you can set up and be prepared. Make sure you do attend 1 live session minimum and listen to somebody else. We have shown that the scores are better when you attend 1 live and listen to at least 1 other one. It's just a repetition and explaining things in different manners. So this week, we are going to be doing chapters 43, 44, hematology, immunology, and the child with cancer. So I'll be going over a PowerPoint first. Once the PowerPoint's done, I do have a Kahoots. It's 44 questions. And these questions are on the concepts that you will see in the future, whether on the exam, on the HESI, on your NCLEX. These are things I know you're going to see again. So it's an immediate testing of the knowledge that you're listening to right now. This week you have due the congenital heart, and you have the cystic fibrosis case studies open. I know I've gone and checked them. If you can't get into them, you need to send a help ticket. Sometimes in pediatrics and the other online, sometimes even if they're set up correctly, because I've checked them all, there's something that you have to do and go through help desk. So just to let you know, that's how I'll be referring you. If you don't know what the help number is, send me a message and I can give that to you. And this week is also your NCLEX questions that are due. So just make sure you follow what NCLEX questions are due this week. So any questions yet? So let's go ahead and start with our PowerPoint. I should end up about 10 to 5. That's where I've been heading off with these so far this week. So, this class, I will be sending you the link to my YouTube. I'll be sending you the PowerPoint. I'll be sending you the Kahoot. So all the information you're hearing today, you will get that. So don't be afraid you're not going to get it. I will make sure. So hematologic and immunologic dysfunction, this has to do with blood. So how are we going to look at a hematologic or an immunologic dysfunction problem? Well, first is the history. Most of the time, hematologic will be bleeding. It will be something to do with being tired, exhausted, fatigued, or having frequent infections. So once we see those things, we'll say, okay, let's draw some blood. And the one blood thing that does help us is a complete blood count, the CBC. It looks at white count, which measures infection. It looks at red blood cells, which carry oxygen, like with anemias. And it does look at hemoglobin hematocrits, which also can tell you if you're tired or not, because if the levels are low, you're not carrying oxygen and you will fatigue very easily. So again, the comments, lack of energy, we can see that. Today, the food sources really don't have a
Good
lot of
afternoon,
good
Professor Markle.
iron.
I understand and appreciate your intentions to be fair to all students. However, I cannot understand the advantage of providing
Autumn,
students in knowing their preliminary.
okay, I did her. Okay, when we get to be 1 year old, we switch from a formula, we switch to whole milk. So now the iron fortified formulas we're not getting. Also, we know in the toddler stage, they go through this physiologic anorexia, which means they really don't eat much. So if they're not eating any sort of vegetables or, liver, which of course is iron, they're not going to be getting all of that good, rich iron source they need. So that's why sometimes we're going to see low iron levels, which would be, a type of anemia. Again, the frequent infections or bleedings, which will point to some sort of problem. So red blood cell disorders. Well, what do red blood cells do? They carry oxygen to the body and give them energy to be able to do what they need to do. If the red blood cells levels are low, that means less oxygen is getting there. So on a little bit of exertion, these children tire out easily. As an infant, all we do is suck, swallow, and breathe. So suck, swallow, and breathe, and trying to eat with a low hemoglobin, low red blood cells, this child's going to run out of oxygen easy and is going to fatigue very easily. So that's the problem with anemia. Now there's all different sorts of anemia that take place. We're going to go into some of them, but children in themselves as infants do not start making red blood cells till after about 3 months old. Sometimes a little bit later. So at 6 months old, we can do a CBC on a normal, healthy infant, and the hemoglobin can be 10 or 11. And that's actually good because we haven't started to make our cells yet. So below that, we would give supplements. Above that, we have to do nothing. So different sort of anemias like I expressed to you. We have decreased red blood cell production, which can be caused by nutritional deficiencies. We don't have iron like in our diet, or the other one that we look at is B12, the intrinsic factor, which means we're not getting what we need for our body. Another thing that can happen is that our bone marrow is not making what it needs to, or making stuff that's just not normal. So the biggest, most difficult, I think, of all anemias is aplastic anemia. Remember that word A, like atresia means no valve, A without. Well, from last week, we have aplastic anemia, which means there's a lot of without here. So you're going to see white blood cells, you're going to see red blood cells and platelets, all going to be really decreased. So that can relate into many problems. Acute lymphocytic leukemia is another one of them. You have no white blood cells. And then, of course, with the treatment, we are going to be having lower hemoglobins, hematocrits, and platelets requiring transfusions, etc. There's a way that we lose red blood cells. Of course, blood loss is the easiest. Something happens and we lose blood, but it could be due to just a runny, bloody nose. Actually, the bloody nose is what brings in a lot of children, and they find out they have a bleeding coagulopathy issue. So nosebleeds, one is nothing, but if you're seeing multiple, it needs to be investigated. Hemophilia, absolutely one of those red blood cell losses. There's 3 different factors, and it's not a factor, and it's not clotting the blood, so you're bleeding prolonged. Another one is ITP, Idiopathic Thrombocytopenia Purpura. Say that 3 times quick. It's very difficult. So we'll call it ITP. When you see P, think platelets. Okay, ITP, that means decreased platelets, and you don't have enough platelets. Again, that helps with the clotting. So not enough platelets, you're going to see bleeding also. And then in some very sick children, usually overwhelming sepsis, you'll see disseminated intravascular coagulation, or DIC. I'm not going to go crazy into DIC because it's extremely complex. And then we have cells that are being born. They're being born fine. They're being made by the body, but they're dying really quick. So you have all of these bursting of cells into the vasculature, and you're going to see things like dark urine. You're going to see the yellowness in the eyes, pale. Your liver, your spleen are going to be increased. So the first one, increased red blood cell production, is sickle cell disease. These cells are shaped in a sickle and they die very quickly. So they're really not helping to carry oxygen around. These children suffer from low hemoglobin hematocrits all the time, chronically. Another thing that can happen is when we have thalassemia. Now, sickle cell is the African-American child. You know, it's sort of related there, hereditary. And thalassemia is the Mediterranean descent. And this is actually rectangle type cells. And these cells burst. The problem with the amount of cells that burst release iron into the vasculature, causing really bad chronic iron overload, which needs treated with iron chelation therapy. So thalassemia and sickle cell are destruction of cells. It could be also due to a immunological type thing, or it could be due to getting chemo and radiation, which these children do need. Now, what do you see with anemia? Child comes in complaining of being tired, looks a little pale. First thing I want to do, I want to listen to that heart. What is the heart rate? Is it beating quicker to try to get oxygen around? Because that's the first thing the heart will do. But as it's beating, you'll hear that whoosh, whoosh, whoosh going on. The reason is there's cells. And when it's a normal hemoglobin hematocrit, they're just pushed together. So you don't hear this swishing. When it becomes anemic, there's more fluid, dilutant around, and you hear them banging off of each other. And that's why you hear this murmur there. If we don't treat anemia or allow it to maintain at a lower level, the heart's going to eventually give up because it's trying hard to beat, trying hard to get oxygen around, and it's not working. So it continues until it fails. Without this oxygen in these cells, you're going to see cyanosis. And oxygen is just like nutrition in a child. You don't get the nutrition they need because of low oxygen, because they're not eating well. Also, you're going to see the growth being retarded. So they're going to be a smaller child too. So treatment of anemia, first, well, you have to diagnose. It is an anemia. Now, we don't just treat the anemia. We're going to give what they need, but we got to figure out why. What sort of anemia is it? You know, what's that underlying, what happened? Is it sickle cell? Is it iron deficient? Is it nutritional, B12? What's going on? What do we need to replace? We will give transfusions as needed, especially if the hemoglobin hematocrits are really low, or if they're, of course, an acute hemorrhage, for sure. So initially, if we have a child who's got severe anemia and maybe it's due to blood loss, first thing we're going to do is replace the volume in the body. Now, remember, once you have a low hemoglobin hematocrit and you give extra fluid on top, the number you had is going to decrease a lot more because now there's more volume and still the same amount of cells. So you are going to see a lower number. Because these cells carry oxygen, we will be giving oxygen therapy just to maximize the amount of oxygen delivered to the body. And we want to let these children rest. They should be resting because we don't want them to burn oxygen running around and, you know, just useless use of the energy. They need to use this energy to be able to eat, to be able to have proper nutrition. So with the assessment, one of them is, I've already mentioned Mediterranean and the African-American child, that they do have certain diagnoses that they point to. So looking at the ethnicity of these children is important. The age of the child makes a difference in getting that history. And just to rule out any internal cause like GI bleeding, we'll do a stool for occult blood to rule that out. Whenever we are working with children, especially something lifelong that's going to require multiple hospitalizations, sickle cell will, thalassemia will, aplastic anemia will. These children, we will be teaching them what's going on, what to prepare for. And this hopefully will get this child with less stress as we need to do these procedures. Again, if we have a child with a very, very low, hemoglobin, and these children are screaming and yelling during a blood draw, they are burning up the little oxygen they have. And we don't want to do that to them because that can make even more complications. So iron deficient anemia is the most common of all. This is caused by an inadequate supply of dietary iron, just like I had told you. By the time they get from newborn to 6 months, they're either getting iron fortified formula or breast milk, and they usually will get some sort of supplemental vitamins in there. As they get to 6 months, we'll add food in, but it is iron fortified cereals that we do give. But then at age one, we do that whole milk, and whole milk doesn't have the nutritional value. So some pediatricians, depending on the child condition, the size of the child, might consider continuing formula instead of whole milk for these children. Another group that gets iron deficient anemia is your adolescents. Adolescents are going through that growth spurt, 20 to 25% of their growth. They're into that body image and not being pudgy. They always think they're always too heavy, so they're not eating as much. Plus, these adolescents are on the get up and go. They're always going social activities, school, studying, etc., and they're just not eating the way they should, and that causes iron deficient anemia also. I describe milk babies by the whole milk, and that's what that means. So iron deficient anemia can be treated very easily. If the child will eat the proper diet, that's actually the most ideal. But if they're not going to eat the proper things, then we can also give iron supplementation. We can give oral tabs, liquid tabs. We can give iron dextran IM via Z-Track to some of the smaller infants who are not going to be eating the proper things. So sickle cell anemia is another type. As I said, it is your African Americans. It comes from the parents. It's, a genetic thing. If both parents have just the trait, each child has a 25% chance of having the disease. So in sickle cell anemia, what do we see? Well, we know those cells are sickled shape. And because they're sickled shape, they get to a bifurcation in a vessel. And one will just not go down right and clog it up. And then everyone tends to pile on top. So on top, it's swelling, the vessel's stretching, nerves are hit. It becomes very painful, very swollen. But down below that obstruction, they're not getting the oxygen and the blood that they need. And it could cause cell death at that point. There's no oxygen going there, which is what all the cells need. So sickle cell also, as I said, is an increased red blood cell destruction. It is not uncommon to get a child, whatever age, into the emergency room in sickle cell crisis whose hemoglobin and hematocrit are 5 and 15 or 6 and 18. And these children will get blood as soon as we possibly can. Because what does blood do? It carries oxygen. They need that oxygen quick to prevent problems. Hypoxemia and, the head, we need to give blood, to all organs of the body. So anything that increases the need for oxygen in a body can cause a sickle cell crisis. Most of the time you're going to see it is with some sort of infection. That's the most common I see. These children are told if they have a fever of 100.5 or greater to notify their healthcare provider, their pediatrician, so they can start them on antibiotics quickly. If they come into the emergency room, many times they'll give them a dose of intravenous antibiotics. And depending on all their other numbers, they'll either be let go home or they will be staying in the hospital for a course of antibiotics. Trauma can cause it, stress can cause it. And the other big thing with children is dehydration. So sickle cells have a trouble going down the vessels. We need those vessels dilated, and we need to keep these children hydrated. If they're not hydrated, blood's not going to flow, therefore you get a crisis. So we do screen all newborns today to make sure. Our goal, of course, is to prevent sickling. And how do we do that? Well, we need to have the child rest when needed, so they're not overshooting the amount of oxygen reserves they have. They need to keep hydrated. If they're outside, they need to have hydration with them, and they need to be constantly taking that. One of those Powerade, Gatorades are the best of all of them for these children. If this child comes in and they're sickling, I've told you that those vessels are small and those sickle cells get caught. The first thing we do, priority care, is to start an IV and hydrate that child, make those vessels bigger. It's not pain meds first, because the pain is due to those cells can't go down. You stretch those veins open, let the sickle cells go by, the pain will decrease. Yes, we will be giving pain medicine, but number one is hydration. Also, heat causes vasodilatation, so heat is a great thing for these children. We will be looking at electrolytes. Many times their potassiums and sodiums aren't right, so we'll be looking at that. We'll be giving blood as they need it, and of course, antibiotics. Many children are on prophylactic antibiotics. They're given one penicillin pill once a day from ages 2 months to about 5 years old, and that's to help prevent. It's a preventive sort of thing. Now, there's no cure for sickle cell anemia. They think maybe a bone marrow transplant, but they're not completely sure with it. Sometimes it works, sometimes it doesn't. These children are immunocompromised, so they do get a lot of infections, and that's why they go into crisis as much as they do. Bacterial infection is the leading cause of death. So as soon as there's a fever going on in these children, their body doesn't have a great immune system to fight. So getting them to the physician, to the emergency room, getting those antibiotics is life-saving. These children do become adults, and they can live into their 50s and longer, as long as they are treated as they go along. You have to go. I'm teaching. Close the door, please. My grandson is here. So what do we do with sickle cell anemia? Well, we need to make sure that we educate them how to prevent these attacks. We know it's early intervention. As soon as we have that low-grade fever, make sure that we get to the doctor or get that prescription called in. Given that prophylactic penicillin, like I've said. And the one thing we don't realize is that sickle cells can occur in the head and in the lungs, and those are your most dangerous. If you have a child with sickle cell anemia complaining of dizziness, headache, or you look at pupils, they're unequal, this is a stroke that's going on. So really, some of the questions, so when did it start? What does it look like? Where is it? The pain, give me a number, etc. And then respiratory problems could be similar to like a pulmonary embolus. It is pain in that area. So you can see how these would be some really difficult and dangerous situations. These children we should treat as normal as possible. Let them go out and play, but we need to be preventative. Keep them hydrated, give them frequent rest periods. And this can help them feel normal, but it can prevent those sicklings. So again, treatment. We are going to first have them rest. We're going to, number one, hydrate them. Many children come in and they're minor attacks. Still, they can go oral hydration, but usually come into the doctor, into the emergency room, we're going to stick an IV in immediately. We're going to draw labs, look at it, and we're going to do electrolyte replacements. give fluid boluses, we're going to give pain medicines, and we're going to see if they do need any sort of blood products. And of course, at that point, antibiotics for infections. One of the things we do in sickle cell is measuring something called reticulocyte count. And it looks at the bone marrow, and it looks at how much cells are being produced by the own body. And it can tell us, what we need to do. Do we need to give blood or not? If we're on the border, the reticulocyte count is going to give us that information. So blood transfusions carry oxygen again. In sickle cell, hemoglobin hematocrit so low, we need that oxygen. So giving blood transfusion can help with hypoxemia and ischemic episodes, etc. So I said thalassemia is rectangle. If you see them, they are rectangular shaped cells. And these burst quick, very short life. The problem with these bursting, the oxygen goes away and iron is released into the vasculature, and it can cause iron overloads. These are descendants of people from the Mediterranean Sea. Now, there's 4 types of thalassemia. You don't have to know which one is which. Just to know that the worst one is called Cooley's anemia. And this child, the only way they survive is transfusions. Now, is it 1 a week, 2 a week? All depends on the severity of their, Cooley's anemia. But these children do need blood to survive. And if you could think of a child who has a very rare blood type, it might run into a problem. So hopefully you're one of those A positives and you can get blood whenever you want it. So thalassemia doesn't show up right at birth. Thalassemia at birth, the cells look normal. And something happens around a month and a half, 6 weeks old, you'll see the cells starting to change. But usually we don't look at CBCs until more things happen, as in failure to grow, that tiring easy, or seeing them very pale and the yellow icteric sort of look to them, then we'll say, oh, maybe we should do a CBC. So sometimes it can go on for a couple months before they really determine it. So usually these children will do the hemoglobin hematocrit. We will do a smear, look at the cells, see the cells look like thalassemia, and then if the hemoglobin hematocrit's low, we'll be giving blood to these children. We also, at the same time, will be measuring iron levels because, as I said, all of it goes into the blood system. So there are oral IV medicines that can be given, and it basically combines with the iron and it's excreted through the kidney, and it works well. Sometimes that doesn't work as well as we need, depending on the severity of thalassemia. These children might need to go under apheresis. Now, apheresis is similar to your dialysis, but you can remove components of the blood. So we can remove the iron from the blood with that. People with thalassemia can live into adulthood, but it's a very diligent going to the doctor, getting blood transfusions as needed, following up lab works, et cetera, et cetera. And these children are going from right after blood transfusions, with very good blood counts, and then really quickly low blood counts. So they're constantly anemic. Again, anemia causes the heart to beat so fast, makes it work hard. So now you're going to get heart failure. Heart disease is going to occur from it. Many times the physician decides to take out the spleen, stop the cells from being produced. But sometimes there is that sepsis post splenectomy. Also, you can go into multi-organ failure, not getting oxygen, not getting the gas and fuel it needs. These organs are just going to fail. And again, bone marrow may be a cure. So what do? We're going to make sure they're compliant with transfusions and getting their chelation therapy. It means getting rid of the iron in their body. These children need to learn how to rest, decrease anxiety, decrease stress, and we need to teach them exactly what's going on. And it is a family disease. This child is constantly in and out, getting transfusions, going sometimes for chelation therapy, apheresis. So it is a real family order. So make sure that we support them as much as we can. And if we're getting all of these blood transfusions, can you imagine complications that can occur and all these extra antigens that these blood gives these children? It becomes, this big snowball, but it's what they need. As I said, aplastic anemia, A without, right? There's two types, but pancreasemia is the all forms, which is the anemia, leukopenia, thrombocytopenia. Well, leukopenia is low white count. Thrombocytopenia, there's your P, low platelets, okay? So you have low hemoglobin hematocrit, low white count, and low platelets. So you can see the issues there. Then the hypoplastic anemia is just the RBCs, but at least you have the immune system with white cells, and you do have platelets for the bleeding, but still you have a hemoglobin that keeps going away. Now, how do we treat aplastic anemia? Well, it's a little bit different. I mean, we still give replacements as needed, etc., but it's treated more like leukemia, which means they're going to be getting the chemotherapy, immunosuppressive therapy. The body is eating up its own cells. So we need to say, you need to stop that body. So let's get that immunosuppressive drugs. Let's make them stop. And again, bone marrow probably is the cure for aplastic anemia. So let's talk about bleeding and not clotting the way you should. So when you think of bleeding, prolonged bleeding, you think of hemophilia. Now, hemophilia is just basically the body doesn't have all the clotting factors it needs to be able to clot blood once they're cut. There's all different sort of factors that they could be deficient of. Now, hemophilia comes from mom. It's an X-linked recessive, so mom passes it to the child. The three types of hemophilia. We think of hemophilia, we think of factor VIII, right? Everybody knows factor VIII. Well, that's one of them. There's also factor IX, which is Christmas disease. And then a scientist named von Willebrand found another factor. So it's von Willebrand factor, but it's also combined with factor VIII. If you have hemophilia and you're bleeding, you will replace the factor. You will, if you have a fever, you take Tylenol, right? You're bleeding, you're going to replace the factor. So how do we sort of figure what's going on with these children with hemophilia? Well, if we see it, now, not all of them do we know immediately. We sort of find it out. We see these bleedings going on. Usually it's the bruising that we see, or nosebleeds that we see, and that sort of makes us go ahead and look at it. Now, the overt bleeding is the easy thing. Now, and of course, bruising we see. The problem with hemophilia is, children like to get up and run, fall down on their knee, and it's a normal bump for me and you, but these children bleed within their knee into their capsules. And what it does, it destroys the joint capsule. So if we're not diligent in treating these children, the joints will become defective and these children could end up in a wheelchair. So it is prudent care of these things and doing the care to stop it, which I'm going to go into. Now, hemophilia is that low factor, right? Whether it's 8 or 9 or von Willebrand's. You will see it with a prolonged PTT time. That's what we get with heparin, right? PTT is heparin when we see prolonged. So that's the same sort of lab value that we will get. But platelets are good, they're working good. And other coagulopathy clotting things like parathyroid and fibrinogen are all fine. So at home, you've got a kid fell down and they're bleeding in their joint. The family at home can do a home infusion. Now, I have a story about this little 9-year-old boy who came into the emergency room. Didn't know if he should take it or not because he had the factor, not so long ago, and they couldn't get a hold of hematology. So they came in and we needed to give it. But he had brought his own dose with him and all the equipment. So the father said, "Can I give this to him myself?" I said, "Why not? You do it at home." I said, "I have an orientee. Can she watch you?" It was probably the best thing I've ever seen. This father and son talked about what vein they were going to use in the arm. He took the powder, mixed it, he had washed his hands, used alcohol, everything, pulled it up into a syringe, and it was in a butterfly. Started the butterfly, taped it down, the son held it, and he pushed it in and took it out and held it until it stopped clotting. And it was, the son got through it, 9-year-old, not a whimper, not a cry. He was a part of it. And I told the father, you're amazing. And he felt good. He said, well, it's my son. I got to take care of him. I said, well, not all parents will. So you need to commend yourself on that one. So that was good because it needed an IV home infusion. Sometimes if you're mild, you can go away with the desmopressin spray. Have you heard of desmopressin before, DDAVP? Diabetes insipidus. Yeah, it's the same thing. And we do use it for hemophilia too. And sometimes we do this aminocaproic acid, with it, but it's all depends on the severity of hemophilia. So hemophiliacs can live a normal life as long as we protect their joints. And we give care as soon as we possibly can, because we don't want those joints to get destroyed. There is some gene therapy going on. It's not completely approved yet, but we're close on this one. So you fell down, your knee hurts. How are you going to treat this at home? What are we going to teach our parents and our child? Well, number one, I like this price instead of just rice, okay? Price is to protect, number one. These children shouldn't be out playing soccer and football and stuff that they're going to be hit up and beat. This kid's going to be swimming or bowling or something else. It's not going to be playing a contact sports because they will bleed. When this kid fell down, bumped his knee, first thing, stop, rest, elevate it, put ice on it, and then put an ACE bandage around it to keep the bleeding from going on. Just like you would with a sprained ankle, same treatment. The ice constricts the vessels, stops the bleeding, and then we'll be giving that home, whatever their treatment is, the spray or the IV, to stop that bleeding. Also, with hemophilia, when we determine this child is that and family wants more children, of course, genetic counseling. Now, immune idiopathic thrombocytopenia purpura. This is P, remember, platelets, decreased platelets. You need platelets to stop bleeding, okay? It's part of the clotting cascade that we have. Now, ITP, and I'm going to call it ITP, it's just easier than that big long name. ITP is something that you're not born with. It's something that could be an acute stage or it could turn into a chronic condition for life. Usually you will see ITP happen where you see a child getting bruising or this petechial looking rash, arms, legs, trunk, doesn't matter where. And the mother's like, but this kid just sits there, plays video games. There's no reason for all these bruising. And usually they come in because they've had nosebleeds, chronic nosebleeds going on. Again, it's showing you there's a bleeding problem. It's usually after some sort of upper respiratory or some sort of infection that's occurred, usually within a month or so before. You're going to see this, and then all of a sudden you're going to see these bruising and petechial rash. So how do we treat this? Well, we are going to, of course, protect them from bleeding. As nurses, any bleeding child, you're not going to give IM injections to. You're going to give them soft toothbrushes, no razors, especially those adolescents who want to shave their legs. Nope, sorry, can't do it. No razors, and we're going to be monitoring all their blood levels all the time. In ITP, it's IV immunoglobulins and anti-D. And then if you look at the bottom, sometimes corticosteroids. Steroids can help with it. So these children, we can get them through. Sometimes they're completely healed and the ITP is solved and they don't live a lifetime with it. Again, if it goes over 1 year of treatment, this is when it's going to be a chronic condition where they're going to need supportive care. So as I said, be careful with venipuncture, watch for bleeding, monitor your blood counts. And as I said, corticosteroids is prescribed. Now, DIC, I don't want to go into this too heavily, but basically the body makes their blood thin by making fibrinogen into fibrin, which makes things bleed. And it's almost, and there's clotting areas. This child is sick. We're going to be looking at all their bleeding things. D-dimers looks for clots, thrombin-time, PTT looking for bleeding. And how we treat this is by blood products and IV heparin. And this is what you have to buy time with. In the infant, we can take blood out and push it in at the same time, and that's called an exchange transfusion. We also use that with hyperbilirubinemia, which is very high levels, like over 20. We'll use it for that. But this is the other thing we do. So it's a bleeding issues, we give blood products and heparin, and this child is sick. You've heard me mention epistaxis many times. I told you this is usually why children come in and why we find things like ITP or hemophilia or von Willebrand's. It's because we're seeing something that doesn't look right. If you're having 3 nosebleeds in a week, something's wrong. So how do we, if a child bleeds, and what do we teach the parents? Well, number one, keep the child calm. Remember, they're bleeding out of their nose, they're bleeding out, they're gonna die because they're just insides are coming out, and that's what these children believe. So put them on mom or dad's lap. Let them be comfortable. That's where they're most common. You know, they're calmer there than anywhere. So put nasal pressure and lean them forward so they're not swallowing all this blood. Because if they swallow it, they're going to be vomiting these clots of blood, and you don't want that. And then it's going to just recause the bleeding to start in the nose. And you hold it for about 10 minutes, and it should calm it down. HIV AIDS, this is an immune problem. It is a virus. So hopefully the biggest thing that causes transmission to the pediatric population is mother to child. Hopefully the mother starts this heart therapy, which is a highly active antiretroviral therapy. So when we're giving that at 22 weeks and then a week after birth, our goal is to take that infant's immune function and give it the best we can. We want to make it the most improved. We want it to be the best immune system it can be. And we do that with these antivirals. Now, if an infant is born of an HIV mother, it does not mean they're going to be HIV forever. If we have started these antiviral therapy when they should and after birth, these children can convert and be normal. I have seen twins, one positive, one negative. So you don't know. Same birth, same delivery, 2 babies, 1 yes, and 1 did not have it. So you can convert them. Remember, with adolescents, we need to teach them how to be safe sex. I mean, we could say abstinence, but adolescents are going to do what they want. So at least teach them what is safe sex. So again, in our goal with this in HIV is to improve the infant's immune system. PCP, pneumocystic pneumonia, is the most common opportunistic infection, especially when you talk about lungs and respiratory. And it usually occurs between 3 to 6 months of age that we'll start seeing these things. We also know that yeast is part of it, but PCP pneumonia is, the most common and actually the most dangerous of all. So with HIV, especially parents, to teach them, let them know what's going on, that they should get these antivirals, to protect their baby. Adolescents, we need to give them some sort of counseling. And, you have an infant with HIV in a nursery that you're treating, you still need to protect the confidentiality of that baby, because you can't say HIV positive, be careful, wear gloves. You can't do that, because we literally should treat all children like they have some communicable disease. So we should wear gloves with all of our infants, and that's why we do. So management of hematologic immunologic disorders, number 1 is blood transfusions. Make sure if you're ever given blood transfusions in a hospital, you follow the policies given. Remember, if there is any sort of possible reaction, and it could be just a fever spike. I've seen normal fevers 98 before I start the transfusion. 15 minutes later, I need to take another one by the policy where I work, and it could be 101. Stop the transfusion immediately. Whenever you suspect any sort of reaction, antibiotics, blood, anything, stop the transfusion, stop that IV immediately. That should always be your priority care with it. And we always will run this under some sort of pump to make sure they're getting the proper dose and not too fast, not too slow. I mentioned apheresis before, that we could take iron out, but we can remove components. We also can take, let's say mom or dad want to give platelets to their baby. We can do apheresis. We can get platelets out and give it to their child. So when both parents have a sickle cell trait, what is the chance that each of their children will have sickle cell anemia? Which one?
A.
Yes, it is 25%. Good job. So neoplastic disorders, we're talking mostly blood and blood forming organs. So leukemia and lymphoma are over half the sort of cancers in children. So leukemia is blood. It is the white blood cells are formed and they're just not formed correctly, basically. It is usually more boys, and peak onset is ages 2 to 5 years old. So it is a very difficult time for nurses. Beautiful child, you diagnose, they have leukemia, and you have the parents now who have the task of going through the whole process of chemo and hospitalizations, et cetera, et cetera. So it is a big, long ordeal, but survivability is really good. These children do really well today. So leukemia, the diagnosis: unrestricted proliferation of immature white blood cells in the blood forming tissue. So they're immature, white blood cells don't work. You can see white blood cells levels on admission of 0.1, 0.05. It should be what, 4 or 5 to 10, and it's really, really low. So they have no immune system. So these children are severely immunosuppressed. So when we suspect leukemia, what am I going to see? Well, usually there's bone pain, fever, general tired, feeling icky, not good, looking pale. I had a next door neighbor girl. She actually was a teenager when she went in, and she complained of knee pain, complained of being really tired, and she had bruising. Went into the emergency room. This is the one they found, a white blood cell count of 0.1. Today, she's a PhD from the University of Miami, is doing very well. But at that time, the whole family was going crazy. And of course, I had to be her special nurse, but that's okay. And I was. So as we talked before, there's blood smears that we do take. And we can see that these white blood cells just don't look right. There's something wrong with it. They're immature. The next thing after we determine, yes, leukemia, we're going to do a lumbar puncture because we want to make sure it's not in the central nervous system, because we can put chemotherapy right into the central nervous system to eradicate that also. And then to look at the blood forming area, which is the bone marrow aspiration, we're going to be looking at the cells there. So those are 3 things that you know is going to happen. We're going to draw blood, find it, do the smear, do lumbar puncture, and a bone marrow. So we've determined, we've done all those things. Yes, it's chemo that we need to start. So there's 4 stages of therapy, but literally it's induction therapy. Now, induction therapy is 4 to 6 weeks. And our goal is to achieve remission. So by the time you're ending induction therapy, the rest of it is just taking care of just that little bit that's left. So induction therapy is your most important phase of chemotherapy. We want to achieve remission. And then it gets up to the point of maintenance, and we're just going to preserve that. As we said, sometimes we need to give a stem cell transplantation to these children, and it's what they need because everything else is failing. So there's all different donors, and it doesn't have to be a match. Mismatch doesn't matter at all. It can be peripheral, umbilical. There's all sorts of ones that we can use. Now, sometimes if the kid is 2, they might have their umbilical blood stored. I know it is an option today. I know it costs money, a lot of money. Some parents do it, some just can't. But if they have, and the child ends up with leukemia, they can do an autologous stem cell transplant. But usually it's an allogenic. And usually your siblings, your brothers and sisters are your best one to get that match from and to get that stem cell from. So leukemia, always going to prepare these children. These children are going to get some sort of IV port in so that they don't have to be stuck all the time. Of course, I said they have pain, so make sure they're medicated. And then, of course, we're going to watch them for infection. We're going to really good hand washing when we're working with these children. We're going to be looking for hemorrhage and bleeding precautions. These platelet counts go down to nothing. No platelets, bleeding. So making sure that we have them on bleeding precautions, soft toothbrushes, and no IM injections. And another thing within leukemia, with the usage of all this chemo, we're going to be having anemia and require blood transfusions. So again, they get anemic and they get tired. So to watch out for these things and to give frequent rest periods to them. You know, nurses who want to go into oncology, especially pediatric oncology, get a little bit experience, go out into the universe. Some of these hospitals pay up to $20,000 finder's fee for a oncology pediatric nurse. So it is a profession to think about if, you know, that's your goal. Prognosis depends. What was your white count? Was it 0.01 or was it 0.1? There's a big difference in your white counts there. How old were they? And was it the leukocytes or the monocytes? Now, there's ALL and AML. The easier leukemia is the ALL. The AML is actually more difficult to cure, but it still is curable. Boys and girls, the difference is actually girls are easier. And then your karyotype. What is your blood type? If you are a very unusual one, a difficult one to find, you're not going to get blood products as you need it. So if you're an A positive like me, you'll be okay. And we'll get blood products when needed without delay. So child with cancer. I mean, we've talked some, but let's go into different types now. So cancer, how do we treat it? We treat it with chemo, radiation, and surgery. And it is all through that IV access, that port that we usually use. So we will know that these children, when we see things going on, we'll see things, that pain again, like I told you, we'll see fever, we'll see bruising, petechiae, they'll be bleeding, they'll be tired. These are things that clue the physician into, there's something going here that I don't like, let's go looking with it. We'll start with the CBC and then they'll go even further. If they have headache, they have vomiting, now we're thinking brain. Abdominal, they might think of anorexia, abdominal pain. So they'll be looking for things. Lymph nodes, they'll be checking those. Remember, you shouldn't feel lymph nodes. So as we're treating these children, you know, years ago, we would treat after we had a symptom. We would give antibiotics after we see an infection. We would also give something for nausea after they vomited. But today, you know, medicine's so much better. We give it before so that we're preventing things. Now, remember these children with cancer, because of the cancer and because of the medicine used, are going to have very low immune systems. They're going to have low neutrophil counts. Neutrophils help fight infections. So you've got a group of patients, and you're looking at, which one's most at risk. If you see one that has a neutrophil count of less than 500, they are really susceptible for infection, and they really need to be monitored closely. And we need to make sure that we're not giving them infection. So hand washing with these children. Getting the specimens, getting good specimens, starting those antibiotics, and keeping these children safe, because no immune system, these children can go into septic shock. Hemorrhage, as I said, those blood levels go really, really low.
But I don't have phone or your phone, because my phone.
Here, go.
My phone needs.
Okay.
My phone.
He wants to use my phone because he wants to do YouTube videos. He knows how to use that phone better than I do. He's 5. Okay, hemorrhage. As I said, platelet counts go very low. Low platelet counts causes what? Bleeding. That's why we put them on bleeding precautions. So we're going to give platelet counts if we need to. We're going to be giving transfusions as needed. But with children that are already on chemo, are already with low hemoglobin hematocrit and platelets, we need to teach them, sorry, you can't ride your bike or skateboard, you can't go out, and do contact sports, because you don't want to hurt, you don't want them to bruise and, causing hemorrhages. And with this anemia, they're not going to have a big tolerance. They're not going to have, enough energy to be able to play as long as they should. And we know anemia is part of that chemotherapy that we give, especially in the beginning, that induction therapy, that 4 to 6 weeks, where we're hitting them with 1, 2, 3 different types of chemo. It all depends what the physician likes, and we're killing cells, even good cells. As I said, nausea and vomiting, we're giving stuff before now, because it's really uncomfortable once they start. They're not going to want to eat. They don't feel like it. These children need to get their protein levels in their bodies monitored, because the proteins, you don't have enough. What happens is your interstitial goes extracellular and you get swelling everywhere. And we don't want to cause that. So we need the protein levels up. How do we do that? Well, high protein diet. Because they're not eating a lot, because they tire easily, high calorie. And because they need the fat, give them all the fat they want, because this helps with nutrition. Their mouths get all swollen. Actually, their GI tract, mouth to anus, is completely swollen and could have little ulcers, and it's very painful. So eating bland, soft foods, soft toothbrushes. They don't give lidocaine mouthwashes, which you would think that the lidocaine numbs it, right? But it also numbs their throat and they can choke, especially if they're already tired. So we don't give lidocaine mouthwashes. And of course, sitz baths can be given. Because of the bleeding and the ability to bleed and low platelets, etc., we don't want them bearing down to move their bowels. So we don't want them constipated. So stool softeners, so the stools flow easy without all of that pushing. These children might end up in the hospital and very ill and on bed rest. These children, just because they're children doesn't mean they don't get decubitus, that they're not going to get foot drop. They get it just like adults do. So making sure that we are monitoring closely. Also, chemo causes peripheral neuropathy or numbness of the hands and the feet. So they're not going to be able to walk well. So giving them assistance there. And they need their pain medicine. Sometimes it could be in the jaw. And if you ever had jaw pain, you try to eat, you can't, because it hurts. I mean, I have rheumatoid arthritis and I get into my jaw sometimes. I can't close my mouth all the way. So that's the day that's, okay, I'll have soup today. Hemorrhagic cystitis is another thing that can occur. Increase their fluids, and always encourage them to go to the bathroom. Don't let them hold it. If they're tired, put a commode next to them. Why not? You just want to encourage urination. Their hair is going to fall out. It's just part of it. Many fathers will cut their hair I know as nurses, I used to bring in colored ribbons and I'd say, okay, what color are we today? Or do we want to be a multicolored? And I would wear a ribbon with the child and that child would feel special losing their hair because it's like clumps all over the bed. Some parents just decide to cut it so they don't see the clumps. And many get steroids. And we know Cushing syndromes, if you're an older child, they feel fat, they feel pudgy, and they don't feel good. So making sure that we don't make it worse by too much salt. And if they are with clothes, make them a little looser so you don't see as much of the bigness as they really have. Most procedures in this, like bone marrows, are given with some sort of sedation. They're going to be given something before. Sometimes they're given propofol, knocking them out, depending on the child. They're given lidocaine to numb the topical area, and then lidocaine, they'll inject deeper to prevent it. Be honest that some of them hurt, but you're going to do everything to make the pain as least as possible. And I think it's important to be honest with children and then praise them for being such brave souls, because it is hard to get some of these procedures. Pain management, remember, it's just not medicine. It's just not the opioid. Motrin, Toradol are two NSAID things that work really well. And remember, it's positioning. It could be hot packs, cold packs, sitting them up. All of those things can help. And of course, use distraction, whether it's iPads and videos and coloring, whatever. Just distract them and it will help. Now we're going to do lymphomas. We have Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma is the lymph system, and it will metastasize to many different places. And it's mostly in the lymph nodes. If you look at these pictures, these are big nodules. They don't hurt. They're painless nodules that are there. So that's the key. It's like, that doesn't hurt. And you're like, ooh, okay, let's look up and see what's going on with this one. With these painless, and it's usually the upper that we see these nodules, you're going to see coughing because it's pressing against, the oral pharynx. Sometimes you're going to see the abdomen being abdominal pain, anorexia, weight loss. And what we'll do at this point when we see that is a whole battery of lab works, but the thing that's going to put the diagnosis down is you're going to do a lymph node biopsy, and that's done under sedation. This child will be getting something so they can get a good specimen. In the biopsy, if we see Sternberg reed cells, this kid has Hodgkin's lymphoma. So radiation, chemo, and these kids do great, believe it or not. But again, it is starting early, doing it, being proactive, getting them to all of their appointments. It is really, an aggressive form of cancer. So we need to do the chemo and the radiation as, it's set up. Many of these children are unable to have children, so they're infertile. Non-Hodgkin's is more diffuse. You don't see the big, thick nodules, but it's basically the same thing that we're going to do. We will be doing a bone marrow aspiration just to look at the cells on this one. And of course, we'll be doing x-rays to look, see if there's any sort of metastasis. And again, radiation, chemo, same thing as we're going to be doing for Hodgkin's. Brain tumors. Now, children, when you have brain tumors, you'll be seeing usually headaches and vomiting, not related to feeding, and headaches which progress to be worse. So the progression gets more and more headaches, more and more vomiting, and it's not related to eating or anything. So when we see that happening, it's even before we see even neurological deficits, we need to look for a brain tumor. So how do we treat a brain tumor? Well, we've diagnosed it, done a CT scan. You can see just on a regular x-ray, you can see a tumor. You can see that little white area, that's a tumor in the dark area. surgery, radiotherapy, chemo, which shrinks it, because we don't want to take more of the brain out than we have to, right? And then we will take it out. Now, can you imagine seeing your child with this big thing on their head? Prepare these families, because it is quite scary. When we're taking care of these children as nurses, many of them you cannot turn on their surgical site. It needs to be on the other way. Sometimes it can't be elevated. They only can be at 45 degrees. And really important is the amount of watching their intake and output. Too much fluid in can cause swelling on the brain and could cause problems postoperatively. So again, our goal is to get these kids back to where they can be, to be the best they can be. But brain tumor depends on where it is and what they had to take out. A neuroblastoma starts in the belly on the adrenal gland, and it's a big tumor, right or left, doesn't matter. And usually we don't feel it in the belly. When we find it, it's already metastasized to the brain. And then if we let it go a while, the belly will blow up like this poor little baby here. And then you'll see the eyes start stretching out, periodontal edema, exophthalmos, eyeballs are bulging. And at that point, the outcome, prognosis is very poor. So these children, they will be doing surgeries to try to give them the best outcome as possible, but it is not a neuroblastoma is not a good diagnosis at all. Good thing is only 6% of all malignancies are neuroblastomas. So that's good. There's not many children. Then we have bone tumors. Osteosarcoma is a tumor of the femur bone, usually male, and they're adolescents. And they'll start complaining of pain in their knee or their hip, which keeps getting worse and worse. And they say, oh, it's because I'm playing football. Oh, it's because of this, oh, because of that. Then they start, really having trouble walking because it's bad. And they go ahead and they do an X-ray and they see this little fuzz on the shaft of the bone, and then they figure it out. If it gets to the point with its prolonging before diagnosis, you will see them be anemic. You'll see them lose weight. And because this is a cancer, it will be, forcing infections in the body. So how do we treat osteosarcoma? Well, years ago, we took the whole leg off. But today, our goal is to save the limb. So we have to take out the whole femur bone, or it's going to spread. There's no other thing. You can't take a piece of it out. It's the whole bone has to come out. So they take the lower leg and attach it to the hip. They give it enough blood supply, enough movement so they can attach a prosthesis to it. They go through the chemo, they go through the surgery, and then it's intensive physical therapy afterwards. This adolescent needs great support from nurses. Wilms tumor is another adrenal tumor. These are boys, ages 3 to 5, African American, and it is a tumor that grows into the abdomen. I have one child who came up from the Haitian earthquake a couple years back, and he only spoke French or Creole. The papers that came with him were only Creole. And the people who had them in the hospital, in the emergency room, were a religious group that took them and brought them. He says, we were just told to bring them directly here. So I'm like, okay, well, let me do an assessment. So I did vital signs. I did a neuro check. I listened to his breath sounds. And when I started listening to his belly, I found a softball-sized lump in his left lower quadrant. And for some reason, I knew it was a Wilms tumor. And I don't know why. I'd never seen one before. So immediately, these are very fragile. They will break off into pieces and metastasize in the peritoneal cavity. Do not touch the abdomen. If you're changing a diaper, be very careful not to manipulate that abdomen. They do the diagnosis usually with just a CAT scan or MRI, you could see an ultrasound would rub on it. So they really don't do that. And of course, because it's with the adrenal gland and the kidneys, they will be doing a urinalysis on it. We do chemo and some have radiation. This little boy didn't. They did surgery. They were able to get it all. And this child did go back to Haiti and he was, quote, cured by the time they got there. Post-operatively, because we've opened this whole big abdomen and we have, worked around the kidney, we're going to be monitoring bowel function and we're going to be monitoring urine and of course infection, because it's such a huge surgery that we did do. But the biggest thing is do not palpate that abdomen. Rhabdosarcoma is a soft tissue. Could be in the eye, the ear, the mouth, the nose, and this just literally just has to be removed. And it could start with just the chronic earache that's not going away. And then they finally look at it closer, do CAT scan, and they find this tumor. Retinoblastoma is a tumor of the retina. You will see what we call a cat's eye, or this white glow. Ever look in the backyard and it's dark outside and a cat or dog looks up and you see this white glow? That's what it looks like. But it doesn't have to be in the dark for these. You will see it just looking at them in normal light. You will see this white glow. The treatment, you have to remove the whole eye. And it has to go through radiation chemotherapy. And then the child will have a false eye that they can put in there so they don't look like they have just one eye there. It is devastating to parents. The last one I saw, the child was 9 months old. Thank goodness there's not many of them. And then germ cell tumors. Most of these are your testicular tumors. Just like women check their breast every month, males should also checking their testicles monthly. 18-year-old boy came into my emergency room triage area where he had been complaining of testicular pain for about a month. The other nurse in the room with me had him, pull his pants down and check it, and it was already the size of a softball. When we took him to X-ray, we did an X-ray and already metastasized into his chest, into his bones, into his abdomen. He died 3 months later. So testicular pain is a big deal to make sure that you do check. So all you boys check, do monthly testicular checks. Liver tumors, we can take out a lobe. So that actually is not that bad. But sometimes we have to take a whole liver. So our survival rate today is better than ever. This is 80%. It might be even more than that by now. We're doing so many different things, combination therapies, chemo, radiation, surgery, and it really has shown that we're, progressing in the forward direction. So our goal in any kid with cancer is to have them with this sign posting on Facebook saying, I'm cancer free. And I think that's the best thing. It's like ring the bell. That was an intense lecture, wasn't it? Did I go on and on and on and on? Were you following me?
It was a little depressing for me. Just because it's kids.
Well, remember, not every patient that you ever deal with or client will live. It's not that they lived or died. It's what did you do for them while you were with them? I have many, many children and adults that I have taken care of that still remember me today, and the families do that have died. I have children who died 10 years ago, and I still get messages from them just to say, it's your birthday, just thinking about you. Chris loved you, or Olivia loved you, and happy Nurses Week. You're the best nurse ever. And you do make a difference. So yes, kids are rough, but it doesn't matter who dies to me. They're all, touch me somewhere. So all of your lights are off here. I don't see anybody. Who wants to win the cahoots today? Brittany wants to. How about you, Thomas? Yeah, you were trying really hard there, trying to write it all down. How about you, Kim, Mary? Yeah, oh, look at you. There we go. I like that. There's 44 today. And again, you in Professor Morris's class, I will make sure that you get all your information. So don't you worry. I have access to all the Canvas shells, so I can make miracles happen. Oh, Malf is back today. If you've never played Cahoots, just go www.kahoot.it, put in the code, and you will get to the game. My Cahoots do go over key concepts. It stresses things that you really need to know. So they are a great review before exams. So let's go ahead and get going. So we're out of here on time today. Good luck, everybody who wants to win. Which statement best describes a neuroblastoma? Remember, neuroblastoma, neuro seems like it's just the brain. Remember, this is an adrenal tumor that usually goes undiagnosed, right? And then you get all of these neuro type of symptoms that are going on for you. So it's made after the metastasis already occurs, but thank God it is not common at all. Thank God. Most common cancer actually is your leukemia. What is sickle cell disease? And be careful which answer you put, because two are close. So it doesn't restrict oxygen, okay? It's the production, the way it looks, it's shaped wrong. Therefore, the oxygen is restricted, and also because it dies quickly. So that's sickle cell. It's the production of them. What is priority treatment for a newborn of an HIV positive mother? So our goal with a newborn that has an HIV positive mother is to boost that immune system on that newborn, because we don't want them to convert to HIV, and we can prevent it if the mother was diligent and immediately after birth we're continuing the therapy with antivirals. What are symptoms of sickle cell anemia? And choose the best one. So it's hand and foot swelling, pain, vision problems, and then the delayed growth, because remember, they're not getting all the oxygen they need. Oxygen is like nutrients, so they're not getting the nutrients for growth that they need. Sickle cell anemia affects which cells? And absolutely, very good. Red blood cells. I am making sure. There are some students who think it's something else. That's why I leave that question, even though it seems basic. I want to be sure you know that. What kind of hematocrit would somebody with sickle cell have, and why? Remember, sickle cells die really quick, okay? It's not that they are not produced. The cells are produced, but they're dying quicker. So that's why it's lower. Sickle cells die faster. What is the treatment for sickle cell anemia? So sickle cell crisis, they come in, they're in pain. We need to dilate that vessel, give IV fluids, medications, antibiotics, pain medicine, blood transfusions if they are needed, and then maybe a bone marrow transplant to help with the cure. And Kim is on fire. Aplastic anemia includes a depression of which cells? Aplastic. Remember, A without. Red blood cells, white blood cells, platelets, aplastic without. And you think aplastic, think of all of them. And there's two types, but mostly it's all of them. Most common type of anemia is? And that's your iron deficient anemia. Absolutely, most common. And we correct that with diet or iron medications. What causes pernicious anemia? That's the intrinsic factor. So it is the B12 deficiency. Very good. How do we treat it? We give B12. Makes sense. Which symptom is the single most common symptom of anemia? I mean, that picture shows everything it possibly could be, but what is the most common? It's usually what brings the mother in with their child. They're like, this kid's not being themselves. They're sleeping too much. They're tired. Or it could be the infant who literally can't eat. So they're losing weight, failure to thrive. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Remember, thalassemia, Mediterranean descent, rectangle-shaped cells. And these cells burst quickly, they die. When they burst, what happens? There is no oxygen, there's no red blood cells because they're bursting. So hypoxemia for sure, and all that iron is spewed into the vasculature. So they need to be on iron chelation medication or apheresis if it's really severe. These children survive with blood transfusions. Nurses caring for a child who's just died and the parents ask to be left alone to rock their child. Should you let them do that? And we really need to let them have their last moment alone. Give them clergy, social worker, patient rep. Do they need someone, and give them some time to say goodbye because it's difficult. It's difficult for the nurse too. What is hemophilia? So hemophilia is the loss of some sort of factor, and we're going to see it in the blood by a prolonged PTT. But the other lab values in blooding coagulopathy, PT and platelet, are absolutely normal. What is thrombocytopenia, ITP? Idiopathic thrombocytopenia purpura, P. What does P stand for? And what do you see? And it is that decrease in the amount of platelets. Remember, bleeding type things is what you're going to see. Thrombocytopenia can cause the following symptoms. So we're going to be seeing those little petechial rashes, bruising, and I'm saying sometimes it's that nosebleed that is happening more than once or twice that brings them in, that makes them do the CBC, and they find it and then put them under the treatment, IVIG and the D, and some corticosteroids will be given on this one too. A multi-select. A child with hemophilia has fallen down, the knee is swollen and painful. The treatment would include what? Well, we want to rest, elevate, contain it, and ice it, right? So hot packs, absolutely not. Exercise it, no, it's going to make it bleed more. Elevate it in cold packs and then give them their home infusion or nose spray, whatever it is. What is a priority nursing action for a suspected blood transfusion reaction? And we're going to stop the transfusion. Any suspected anything going into a patient, you're going to stop that, whatever it is. Very good. A child is admitted with neutropenia. Which nursing action takes priority? Well, what does neutropenia mean? That means they can't fight infection. They don't have the white cells that are able to do it. So as a nurse, what is your priority treatment here? And it's to wash your hands. Now, contact precaution is when they have something I can get, like C. difficile. No, I don't want that. It's only strict hand washing. You don't have to do any other isolation. Again, it's washing hands and putting a mask on if you think you have a little cold or something, but it's just protecting that patient. You don't need full garb. Which symptoms would a healthcare professional expect to see in a child with leukemia? We're going to see that bruising, they're tired, their bone hurts, just like my next door neighbor. Her knee hurt, she was bruising, she was tired, and she ended up with leukemia. They're very classic symptoms. Your child with ALL has recent lab results and the platelet count is 10,000. What is your nursing action knowing that lab? What do you worry about with platelet count of 10,000? And that's bleeding precautions. No platelets, you're gonna bleed. Doesn't matter what child with what, you ever see platelet counts that are low like that, below 50,000 even, you are gonna be concerned on bleeding. So you're gonna put them on bleeding precautions. Child with Wilms tumor, which action by a nursing student causes faculty member to intervene. Wilms tumor, adrenal tumor in the abdomen, 3 to 5 year old males, African American. You're not going to touch that belly. Remember that it's really fragile and it will break off and put pieces into the peritoneal cavity. And we do not want to do that. We don't want to spread it. Cancer of the body's blood forming tissues, including the bone marrow, is called what? And that is leukemia, okay? That's absolutely what it is. Blood forming tissues, and the bone marrow is leukemia. Cancer, it's what it is. Unproliferated, immature white blood cells. All of the following are true concerning a neuroblastoma except it's not common. Remember, it's that big lump in the abdomen that can start crossing, gets bigger, it grows, okay? It's in the adrenal gland, and then sometimes you don't know it till it's in the brain and you're seeing the bruising around the eyes, the exophthalmos going on, and then it clues you in. And by that time, it's too late for the child. Most common clinical manifestation of a retinoblastoma. This is the one that you look at the eye and you see that shiny white. It used to be the flashes on the cameras years ago that you would see the eyes turn white. Same thing as looking out into the yard and seeing an animal and seeing those shiny whites. It's called cat's eye reflex. Again, the treatment is removal of the eye. True or false? Immunizations cause autism. They think that the chickenpox vaccine causes it because we diagnose autism about 2 to 3 years old. And it's absolutely false. Immunizations do not cause anything. All they do is prevent diseases. A child's complaining about these skin markings for radiation therapy. You should be told what about these things? A child needs radiation therapy prior to having surgery to shrink this tumor. And you have these, usually they're purple, bluish purple marks that they put there. And these are there to guide the radiation machine. So you need to leave them alone. So they cannot be washed off, or they have to go back and remark it, which takes time and energy. We'll be upset. Multi-select. Nursing care of a patient with immune thrombocytopenia purpura, ITP. What do we do for this? So ITP, P means platelets, which means low platelets. What do we need to do for this child while they're in the hospital with us? So no IM, all bleeding precautions, right? And those corticosteroids, PRN, yes, that is part of the care with the CBC. But unlike sickle cell, these there's no clotting in the blood vessels. You don't need to dilate them. They don't need fluids. All you need to do is prevent bleeding, give corticosteroids. You can give the IVIG and the D, and that can help alter it. When distraction is used, it helps to do what? You know, distraction is something that's so beautiful. It could be watching the TV, it could be playing cards, it could be an iPad, and it takes this child's mind off of everything. And it's something in pediatrics that we need to use as much as possible. What assessment question needs to be asked to a child with possible rheumatic fever? I have a couple questions from last week to reorient you here. And rheumatic fever is due to an undertreated or not treated strep infection. There's a bunch of diagnoses that goes on, the erythema marginotum, you know, big rash. It could be nodules, could be joint pain, fever, malaise, and then the chorea when they're not walking well. We treat it with long-term antibiotics, and usually all of the symptoms go away, unless it's already gotten to the heart valve, and the heart valve then will need to be fixed, repaired, replaced. Signs and symptoms of asthma. It's all of them: coughing, shortness of breath, tight, chest tightness, retractions, expiratory phase is like really long, so you can breathe in, but you can't get it out. It's not a great thing to have. It's really a struggle to breathe with asthma. Multi-select. Absolute contraindication for nasotracheal suctions include which of the following? Suctioning or looking or using a tongue depressor shouldn't be used because what it can do is just really increase the inflammation of the oral pharynx, and you already have a compromised oral pharynx, and that's with croup and epiglottitis. The other two, really, you can suction. It doesn't cause that problem, but because epiglottitis and croup are all this upper airway here, which occludes the airway, that's why those are the ones that are contraindicated for. Iron dextran is given which route? Iron deficient anemia. Some children might need to get iron dextran. How are we going to give it? And we're going to be giving it IM-Z-Track. It does burn the tissue and it also discolors it. What cancer may present with painless, firm, and large cervical nodes? Painless, that's the key word here. And that's Hodgkin's lymphoma. Very good. Thalassemia major is treated primarily with Cooley's anemia. And Cooley's anemia is treated with blood transfusions. Remember, the blood cells just burst within the vasculature, your lack of oxygen and iron is spewed there. So blood transfusions give them that oxygen that they need. And then iron chelation therapy to remove that excess iron is also the second component of the treatment. True or false? A yeast infection is an opportunistic infection of HIV. And absolutely it is. You know, we think yeast infections are benign, but just think of an infant with a mouth and you get these big clumps, it can obstruct the airway. So a yeast infection does occur with HIV, but it can be dangerous if not treated. That good old nystatin that we give, those swish and swallow things, put it on their tongue of these infants. A multi-select. Treatment of an osteosarcoma includes osteosarcoma is usually adolescent males, and it is the femur that has a cancer on it. Usually it starts with pain, the knee, the hip, that gets progressively worse. They do the x-ray and they see it. Treatment is chemo, radiation, and hopefully we can salvage that limb. Amputation is the absolute end thing that they would do. They do try to salvage, but stem cell transplant's not going to do anything. It has nothing to do with it. You got to take that bone out. That's the only treatment for it. Who are the best donors for a bone marrow transplant? I mean, you're the best, but most of the time it's the siblings, and that is the best that we can get. And it's allogenic. Know the names of bone marrow transplant types. What is the most common opportunistic infection for children with HIV? Most common. And that's your PCP pneumonia. Candida, yeah, it happens, but it's the PCP pneumonia. And remember, we need to work with that respiratory center and make sure that they are oxygenating as well as they possibly can. What would you consider to be neutropenia or a low neutrophil count in children? I mean, what we're most concerned about is less than 500. Usual counts are over 1,000, but 500, lower than that, really be careful. And how do we treat that? Good hand washing. You know, just being smart in the way that we deliver care. A primary characteristic of a brain tumor is what? So remember, it is headaches, it is vomiting, but the symptoms are becoming worse. So it's like a progression of symptoms. So you might start out with a little headache once a day, and it becomes worse and worse and worse as that tumor grows in the brain. And last question, a child is receiving the induction of chemotherapy. What does that mean? And that's the initial 4 to 6 weeks of chemo, and the goal is remission. The rest of the chemo is to knock out those few couple cells that are left, and then prophylactic to keep them in remission. So let's see how we did. Number 3, we have Kim. Good job, Kim. Good job. BCWS number 2. Number 1, AR. 4, LPKI. Very good. What I want you to do is sign your attendance attestations. I have gone over everything you're going to see in the quiz. So if you want to go ahead and do your quizzes, go for it. I have covered it if you're comfortable with it. Or if you want to review again, review again. But I know everything on the quiz that I have discussed. It's been a pleasure. I'm glad to see you all from Professor Morris's class. I will be doing my review on Thursday at 5:30 for the exam if you want to join me. But again, you're going to get all the recordings. They will be there for you. So next week we'll have the exam. So thank you, everybody. And I'll tell Professor Morris, who was here, so you don't worry about it. Thank you.
Bye, Professor. Thank you.
You're
Bye,
always
thank
welcome.
you.
Thank you.
You are welcome.